Yeah.
Screen share,
Steph, could you share that for me, Steph? Or do you have that?
Yeah, I'm just not used to sharing on Zoom, so give me just 1 second. Let's see if I can get to the right screen. Can you see it? Can you see the agenda? It says I'm screen sharing.
Oh, there it is.
Yep.
Okay, just a little bit of a lag.
All right. Well, if we're good to go, I'll call the meeting to order. We have our agenda that was sent out, the minutes along with that. You should have got an email yesterday at 5:16 p.m. No, actually Monday, 5:16 or 5:17. There we go. With the information you need to, sure you've already had an opportunity to review that. It included our financials. Also had, of course, a follow-up conversation with the standardization of plans. All right. With that, I'll entertain a motion to approve the agenda.
So move, it's Jenny.
All right. Motion by Jenny. Do we have a second?
I'll second, Desi.
Second by Desi. Okay. Motion is second. Any discussion? Any discussion? Any discussion? All right. Those in favor of the motion signify by saying aye.
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 Any opposed? Motion carried. All right. Number 2 includes 4 items under our operational update, and I believe we were going to start with presentation. Am I right?
Yes.
Yes.
Okay.
Yep.
So I'm just going to share my screen again once I get to the presentation. Okay. Okay. Can everyone see my screen?
Yes.
Okay. So the operational update for today, we have a few things.
I think, Steph, I think we were going to start with the Digby presentation. Was that?
Aren't they jumping on at 12:15? Are they already here? Or 1:15 your time?
They are on. So
Okay,
we could go through the first stuff, whatever works best, I guess. If we want to go through the
No,
first
if they're on the
items.
call, let's have them do it.
Okay, perfect.
So if Digby wants to share their screen and their presentation, that would be
Right. Well, thank you, Stephanie.
So Digby was going to share more information. On our last meeting, there was talk about a study that Digby was asking NDPHIT to be able to publish a study. And so there was questions. So we just asked Digby to come on to kind of give a general overview of what they were looking at with the study. And then also for them to be available for any specific questions that you guys may have relating to the study. So.
And just as a refresher, Digby does provide the GLP-1 management for our weight loss drugs. Members who have diabetes are also welcome to use their services. And we've seen significant, really good results with membership who have participated. And with that, I will turn it over to Ranjan to introduce themselves.
Great. Well, Stephanie, thank you. And good afternoon, everyone. My name is...
Just 1 second.
Okay. My name is Ranjan Sinha, and I am the founder and CEO of Digby Health. I have with me Dr. Garima Sharma, who is head of care, and Dr. Inti Pedroso, who is our chief bioinformatics scientist. And first of all, I want to thank the North Dakota Trust for giving us the opportunity to serve your community. And we have been working with your community for the last almost over a year to help them improve their health, prevent and reverse diabetes. So I wanted to share some findings, and then we are really seeking your permission to initiate a study that I think will demonstrate the effectiveness of the program and the cost savings that this has resulted in. Hey, Randy, how are you? Good afternoon. I'm going to share my screen. Do you want to say anything, Randy, before I jump in?
No, yeah, I think it would be great if you could just kind of dive into some of the results, and then the what your recommendation is, and kind of the parameters that you talked about in terms of doing this study.
Fantastic. So for folks who may not be familiar with Digby Health, we treat and reverse food-related illnesses, obesity, metabolic conditions, and digestive health. And we do it in a very unique manner where we use the person's biology to both change their biology in terms of how it's interacting with the food and to even change their behavior, because we consider behavior part of biology. The fact you struggle sleeping is the fact that your body isn't producing certain kinds of chemicals or metabolites. The fact that you crave at 11 o'clock at night is driven by an underlying set of hormones. So we are able to understand that and try to treat it. Our promise to our clients is, this is a 6-point promise. First, we want to make sure that we effectively outreach to them and make sure we are signing up the high cost claimants, the members of the community that need our care the most. We are committed to bringing innovation. We want to make sure the kind of advanced tests, the devices we offer, is something that is affordable and accessible to everyone in the community. Our goal is to ultimately lower the total cost of care, and something we internally talk about, to go beyond vibe ROI, beyond saying, oh, 2 members loved it, somebody anecdotally hearing something. We want to make sure we can look at your claims data and actually validate the return on investment. Part of that return of investment is driven by our commitment to reduce or eliminate certain kinds of medication and at least try to impact people foregoing elective surgery because their symptoms have disappeared or significantly mitigated. The next promise is to provide high level of member satisfaction, which we measure through NPS scores. And then ultimately at the foundation of all this is to make sure we are delivering clinically significant health outcomes. So we launched about a year and a few months ago, and to date, we have about 644 members of your community that have signed on to a program. That's about 10.8% of your total population, eligible population, and that does put you in the top 10% of the data that we see in terms of the percentage of people signing up to the program. Your members had really 2 pathways to at least tackle their weight and obesity challenges. One was a lifestyle pathway that is purely Digby's Food is Medicine program. The other was to take a GLP drug, whether compounded or branded, along with the Digby's GLP pathway, the lifestyle pathway, sorry. And the results are people who signed up on the pure lifestyle, 86% of them have lost weight. Over half of them have lost more than 5%, which is clinically considered a significant reversal of various underlying pathways that cause disease. People who adopted the GLP drug and the lifestyle, perhaps not very surprising, almost everyone lost weight and about 90% achieved more than 5%. the way the program was structured was to really give members choice. When members signed on, they were educated on, they have two pathways. What are the pros and cons of each pathway? And interestingly, about 25% of the members that were eligible for the drug decided they will forego the drug route and choose Digby. And as you can see in the data, 90% of them lost weight. 60%, and I think the creative design that was done by Randy and his team, 60% of them selected the compounded GLP option, which it fundamentally allowed you to offer a GLP drug at a much lower cost. Some of these things are changing with the new announcements that you have seen, which is all, I think, overall great news for the community and any employer. Probably the other most powerful thing of our program was only 6% of the members who went on the GLP drug had GI side effects, when typically the industry average is about 30%. And partly that comes from our focus on looking at the gut microbiome, looking at the gut along with weight and diabetes. Looking at the gut health results, 80% of the people who came in, we clinically evaluate their GI condition. 80% of them saw clinical improvement in GI conditions. Probably the most notable is the number of people that came into our program. Almost 1 out of 5 had what is called severe IBS symptoms. We effectively cut that into half over about 5 or 6 quarters, and people who were asymptomatic basically again went up. And it didn't matter whether you were on GLP drug or not on GLP drug, we were able to deliver this kind of result. So behind all this, beyond a lot of science, genetics, microbiome, one of our patented methods that drives this habit change when it comes to food is we have made this very simple. We don't start with telling you get on a keto diet or give up all gluten or give up all carbs. We start with your meal. You take a photo of your meal. Within 30 seconds, the system recognizes what's in your meal and then gives you a point based on how well the food is aligned with your biology, based on its ability to burn fat. Is it causing any kind of inflammation because of food allergies? And how is it supporting your gut health? And a perfect meal is 14. And so as you can see, this becomes a very convenient tool. You're walking into McDonald's, you want to eat McDonald's, you can click what you're eating at McDonald's, and it'll give you little tweaks you can make to improve the score. So when you look at this data of behavior change when it comes to food relationship, your community, when it joined, their average score was about 10.5. Any score above 12 is associated with sustained weight loss, improvement in metabolic and gut health. Anything below that actually is quote unquote disease causing. And as you can see, in about 4 quarters, your community was eating above that line. And this was not a packaged meal, or this wasn't a rigid diet. This was their own food and how they slowly evolved their meals to a much more healthier format. 87% of the people logged their meals. 42% reduced or eliminated using of processed food because the app is able to recognize. And this is a recently introduced feature. You can walk into a grocery aisle, scan on the barcode, it'll pull your biology data and tell you whether this particular packaged food is going to be helpful or harmful for your health. We recently published a study, and Inti and his team worked hard on it. This, I think, is across 8 employers, does not include your data. And these are the kind of financial results that we are able to demonstrate, and this is going through a peer review process, and we expect it to be published. Per year, per member, about $3,000 saving in managing diabetes, primarily driven by decrease in pharma utilization, about $9,000 for GI disorders, primarily driven by lower ER visits and people not some of the selective procedures they decided to forego. About $5,000 saving in obesity management, again, because of reduced outpatient visits, things going for back pain, knee pain, and about $1,700 for mental health, because our ability to improve mental health through the gut-brain axis, improve production of serotonin, GABA, those kind of metabolites that our body does have a capacity to produce if you feed it the right way. So what we are seeking your help and permission is to conduct a similar study for your population and measure the ROI and health impact pre and post Digby care. So we will take a cohort that has signed up to Digby and look at a similar cohort, match them on their demographics, their claims that did not sign up on Digby, and be able to see, is there a change in claims utilization, medical and pharma, over a 12-year period. We want to do a GLP program analysis to see, have we improved tolerability of the drug? Because people who actually need the drug, if they can't, because of nausea or diarrhea, can't use it, it's really money wasted, but more than that, a person's inability to get the care they deserve. Percentage of people that avoided GLP initiation saying, I'm okay, I don't need the drug, I'll pursue a food-based only route. And then percentage of people that after 6 months, after 12 months, we have been successfully able to get them off the drug. And because of the change in their food habits, their base biology, can they maintain the weight? And then we will measure a series of clinical and metabolic outcomes, weight loss, H1C reduction, cholesterol, lipid profile, blood pressure, ER visits, and non-alcoholic fatty liver disease. So the framework we are proposing is to take about 150 active participants, match them with a control cohort for demographics, comorbidity, and we are requesting access to your medical and pharma claims data for that particular time period. And once we have the data, it'll probably take us about 6 months to generate the report. And at that point, we would like to, with your permission, take it for a peer-reviewed publication. So I'll open it to any Q&As, but that's the broad request we have.
I just have a question. So, do those 150 people know that we're allowing them to, like, do they have any say over, if they are to be included in the study, or is that just all the board's ability to release that data? Will they know that they're being part of a study?
Well, the study would be anonymized, so there won't be any individual PHI information. So there'll be no reference to any individual. The people, there is a feature in the app when somebody comes in, and you can opt into a study. And so we'll only take people who have decided to share their data for a study.
Okay.
And there is no health information, private health information that is at all a part of the study.
Now, I know we've got contracts in place between Blue Cross Blue Shield and Digby as far as like non-disclosures, et cetera, and the corrective of EAAs in place between NDPHIT and Digby. Are you already receiving claims information from Blue Cross Blue Shield, or is this additional claims information based off of, in addition to what's already been requested?
Oh, Randy, do you have, I believe we are not for North Dakota Trust. Is that correct? That's why
I don't think we have any, I don't think data is being shared, even though there was supposed to be a setup. Blue Cross has not completed that. And so even though the agreements are in place, they have not made the connecting point. So I think we would have to, with the agreements in place, determine the best way to securely procure the information based on those who've opted in. And then we'll have the ability to at that point, it may be just a separate project because of the fact of their lack of integration that they have not completed.
When we talk about the 150 with Blue Cross Blue Shield, are they, they're not the same people, right? They're not the same people that are participating in Digby and looking at their prior information. You're looking at a separate cohort that didn't participate in Digby for the same time frame. Did I understand that correctly?
So Stephanie, the way this works with at least other employers is we will receive the full claims file, all the eligible members, and we will statistically sample 150 for whom we have the permission, and we will match it against, we'll find a similar cohort based on demographics claims that have not signed up on Digby. So they would typically transfer the full claims file, and it's a relatively simple procedure. So we can definitely, we do that for probably every health plan.
And so the full claims file would contain PHI, but the study itself would not. Yes.
Yeah.
It's de-identified to a member, though. It's de-identified.
Correct. It is de-identified. Yeah.
So you're just looking at demographic information for the extraction comparison, as opposed to member identification of any form.
So when you say the full claim, is that our entire membership that will be de-identified that filed a claim in that period of time? And then you would then pull out the people that you're working with? Am I understanding that right?
So the claims file would have the full information. Anything that will be used in the study will not. So we would need to know which of these 150 whose data we need to measure. And we do need to figure out which set of people in the matching cohort and what their data is, but none of their names or any PHI will ever be published. So hopefully that.
And also, just so the board knows, we do a similar data share with our Plan IT platform, which is a reporting platform. It's de-identified, but we can segment claims to demographics. So we can segment, age, sex, and I'm thinking that it's probably a similar process because we had to set that up. And we run a monthly data warehouse report from our own Plan IT system that we can look at financial information, we can look at clinical information, and that's actually where we produce a lot of our reports that come. So I'm assuming we'd follow a similar process, and then it's just a randomly selected process cohort to the demographic that you're trying to compare to.
Correct.
Okay.
And then the benefit to the board will be, you guys are of course using it to, to show that this worked. Will there be you mentioned that this will be a study and, all of that. I mean, is there a come back to the board? Share information
the savings that it has created for the trust.
Okay.
Mike, I want to just piggyback on your question because I want to make sure I'm understanding when you're talking about pulling the full medical claims of our group. So are you saying that you'd be just taking the 150 that have decided to participate in the study, or you're saying claims of our entire trust? I know it'll be de-identified, but are you talking, is it just the 150 that have agreed to be part of the study, or is our entire group's information going to be included to do a comparison?
Well, for the matching cohort, we would need the entire data because that's how we would know that which group has a similar demographics, similar, obviously gender, similar claims. And this is at least is a relatively standard procedure at this point. And as Randy mentioned, there are probably other tools that are accessing that data for different purposes. But it in no way compromises their their personal health information.
And then in addition to that report being available to our board, knowing how the program has worked, would any of this data or information that you collect and determine the outcomes, would it be used in any other areas or just specifically for our membership and board?
So one of the things we are requesting is if you feel this would be valuable to you, to go through a peer-reviewed process and publish it in Journal of Health Economics, something that can demonstrate the effectiveness of the board in its ability to manage healthcare cost.
As an example of a claims file sharing, we're going through the process of trying to get an audit in place with Prime Therapeutics. If you recall, we're trying to get your pharmacy claims audited. One of the requirements of that is that they get the full claims file as well. And so again, we have all of the proper HIPAA BAA agreements in place in order for them to do the same thing. They pull a cohort of the claims, run it through and decide which ones they want more of a deep dive on. And that's just an example of, where in the industry, a claims file sharing process is standard. So it is something that does occur on, as needed and on an as needed basis. So, and that's why we have the HIPAA BAAs in place, because that basically says they cannot violate that protected health information. They cannot do anything above and beyond what was agreed to be shared for. That means they can't sell the data. They can't do anything with that data outside of the study that they're performing.
Yeah, I think we're just, obviously from our standpoint, we're just asking those questions, right? I think we should be as a board.
Yes.
I think the other thing I would say too is that, some people might say, well, I didn't check the box because I didn't do any Digby, that says I wanted to be researched, So I mean, because if, we're pulling outside, a similar cohort model that isn't in the Digby Health, I don't want to beat a dead horse here, but just know that, it's important that we, this day and age that, we're concerned about privacy and personal data.
Inti, I have one question for you. Perhaps you can help mitigate that concern. Once you pulled a match cohort, can we send out basically a permission? And let's say 20% of them said no, then we could probably seek out would that in any way impact the study?
We can do that. We can match every member that enrolled to Digby to more than one member that didn't enroll. So we can use a ratio of 3-to-1 or 4-to-1 to account for the possibility of some members that did not enroll that would like to decline their participation in the study, such that we can retain enough data. After we have selected the cohorts, we go through a process which is called Safe Harbor, which is actually part of the HIPAA protocols, in which we de-identified any reference to the individual, including address, emails, telephone, names, surnames, date of birth. All of that gets encoded into the analysis, such that once we start doing the analysis, we actually don't know who is who. We just have their data. So that is also a standard procedure that we follow.
So, Michael, we could proactively seek their permission after that.
I don't I don't want to beat a dead horse, but I probably feel comfortable with that. Board, I don't know, I've been chatting this whole time, so I mean, do we want to, I assume we want a motion and a second to move forward, and does anybody have a motion to get us rolling, or any other clarifying questions?
We did actually motion in the last meeting. There was a motion and approval to explore, have them do the study with the intention of, once it comes back, that we have the final say whether it's actually published or not, and go through legal and all of those things. So all of that had been kind of done at the last meeting, but this was more so because there were some questions kind of about the study and things like that. So if you want to do another motion, but there was a motion at the previous meeting to actually go forward with exploring it, so.
Sorry, that's my fault for not being here last time.
That's okay. No, I just thought
but,
I'd mention it in case somebody's like, wait, now are we doing this again? So
yeah, board members, what are your wishes? You already have something that's been approved. Are you good with it? Do you want to make any amendments? Kevin's got a thumbs up. Give people a second. You want to make a motion? Keep it same. See thumbs up. Okay. Looks like we are heading forward. So it doesn't seem like, I think your original intention sounds like that was approved, and I don't think you need to do the process at least I was talking about. So, okay.
Well, appreciate
Yeah.
the gesture and the support. Thank you.
All
Thank
right.
you for your time.
thank you all for joining.
Thank
Thank you.
Take care. Bye-bye.
All right, I got to pull back up the agenda here. Next item, okay, we approved the agenda. We were starting an operational update. We had Digby go first. Looks like that item 2A. We have not
No.
approved the consent agenda yet with the minutes. Let's start with that. Let's approve the minutes, and then we'll get to number 2 there.
Chris, I will to approve.
Okay. Second by Cole, looks like. Any discussion? Any discussion? Okay. Motion. Yeah, motion approved. I should have done a vote, but we're right. Okay. Item 2A, net results impact.
That's where I will start sharing my screen again.
Sorry I disrupted you before, Steph.
No, that's okay. I got to get with the program here, so keep me in line. All right, let me know when you can see it, because I think there's a little bit of a delay.
Yep, it's up.
Okay. So at our last board meeting, there had been a question about who would be impacted by the net results changes. And so the October pool has already gone through this process. 136 members actually received letters. Of those 136, 124 are due to drugs not being covered under net results. And that's a little misleading. So drug classes have multiple drugs within the class that are covered. So their particular name brand of drug, or their particular brand, not necessarily name brand, but their particular drug may not be covered, but that doesn't mean they don't have an alternative solution under that same drug class. Because how many different brands of aspirin can you get over the counter? It's the same sort of logic. So net results is moving them to a more cost-effective drug within that same drug class for those 124. And then 12 are the result of a negative tier change, meaning that coverage is still there, but will be a higher cost. And then, of course, the January pool, 154 members will receive letters. I believe that another follow-up letter is going out today for anyone who wasn't first initially captured in this first 154. As prescriptions continue to get filled, they're continually watching for anyone who might be impacted. So I believe another letter is going out today. And then 135 are due to the drugs not being covered under net results. So they, might not be able to get that particular specific prescription, but they still have options under the drug class to get those drugs filled. And then 4 have a negative tier change, but a higher cost. Any questions on that? If there are no questions, that would bring us to the next agenda item, which is the E&I Bree Health Renewal. That is the employee assistance program that has been implemented that does so much more than employee assistance. Like they do all kinds of things. But the total benefit cost for 2026 is increasing to $82,555. They are offering a 2-year rate guarantee with that. This is the first increase that we've ever received from Bree Health since we've implemented them. So I think we've got 3 years with no increase. It is just an increase of $3,555, which is just under $300 a month of an increase. This is what they're proposing. We actually think it's a very reasonable proposal, especially considering that the cost of the provider services is going up exponentially, which Randy's going to speak to a little bit more in terms of our market update. But so that's, from our perspective, it seems a reasonable increase, and they've locked us in for 2 years. But we did look at utilization, and the 2025 utilization has not dropped. It seems to be tracking in terms of the same levels as we had in 2024. EAP is always an underutilized. I say underutilized. It's not really underutilized. It's got low utilization because only the people that really need it use it. So we usually see between 5 and 6% utilization on the program. We're trying to promote the EAP for the other services that they provide when we talk about it going through the renewal process. I'll mention that, not only do they have the EAP, but they also have a concierge service that can help you with planning trips. They have a health advocate. So if you are receiving a ton of different claims because of a service you've recently received and you can't make heads or tails of it, they actually will help you as a member walk through what that means and determine what you're supposed to pay on the bills, which to me is like having, your own personal assistance with your own health claims. So that's the service that they provide in addition to the EAP. But anyway, our recommendation is to renew with the E&I proposed renewal. And I believe a board action may be required on that.
All right, we have a recommendation to renew with ENI, Bree Health. Do we have a motion?
I'll push that one. This is Keith.
Keith? We have a second.
I'll second, Desi.
Desi, okay. Any discussion? Any discussion? Any discussion? All those in favor of the motion signify by saying aye.
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 Any opposed? Okay, motion carried. Back to
I
you.
will go
Steph.
ahead and let E&I know, and we'll get a contract in place for signature after we've got this confirmed. The next item is the GAP renewal. The GAP renewal is in a rate hold for 2026. They did inform us, Transamerica did confirm that it will increase in 2027, at which point we may want to consider taking it out to bid just to see, as it's always good if you're getting an increase to leverage that pricing, but it's GAP. So rate hold, no action needed. All right, that brings us to an item that also is not on the agenda. It's come up through a Blue Cross Blue Shield communication. I don't know if anyone is aware of this, but the high deductible health plans are now eligible to offer telehealth services at no cost before the deductible is paid. Currently, your high deductible health plans, your Blue Saver plans, offer telehealth services, but they're subject to the deductible. So the member pays that cost of that care. They can also use their own physician if they offer telehealth services through their office, and it would just be charged at whatever that physician charges for. Your PPO plans also offer telehealth services, again, at the cost of whatever an in-service rate would be. So a PPO plan would be subject to a copay. Based off of this change in terms of being able to cover any telehealth service at 100% for HDHP plans, effective January 1, 2026, Blue Cross Blue Shield has adopted a policy in which they will elect to coverage all of the telehealth services for their entire book for both your Blue, which is the PPO plans, and the Blue Saver plans, which are the HDHP plans, at 100%. And this change will become effective at renewal for other groups. So any group renewing January 1, 2026, this is what they're doing across their fully insured board. And they would do this automatically for NDPHIT as well, unless NDPHIT chooses to opt out. And this would be covered at 100% for any service, whether it's your doctor or through TeleDoc, which is their new telehealth vendor partner going forward. Amwell is their partner currently, but they're moving to Teladoc for 2026. We looked at the utilization for telehealth, and the next slide kind of goes into that. I'll kind of jump forward to see if we can, it's not moving. I'll look at that slide in just a minute, but basically there are 6 groups that have Blue Access plans that NDPHIT would have to have the Blue Cross Blue Shield program manually update those plans to include those services covered at 100%. So all of your Blue Saver, all of your Blue plans are going to have this happen to them unless you opt out. Blue Access is a different plan design, and we would have to manually ask them to add these 6 groups to this process for the January 1 renewal. This may mean that telehealth claims are held until they get their system set up. This could be a month or so after the benefit goes into effect, but telehealth is a low utilized service. So, and if the member's not having to pay a cost, there's really no impact to the member at that point. Now, we do know that the October pool will automatically get this benefit if you don't opt out as of 10/1/2026. But we did ask, well, what would happen if we just moved all of NDPHIT as of January 1st? There are 79 groups in the October pool, and they would, if we were to do this, we're still waiting to see if we can get this approved. If this were to be approved moving forward, it would be the same scenario as the Blue Access plans. We would be last in line for the October pool because all of the Blue Cross Blue Shield plans are moving to this. And then the October pool would be having their claims held until they could actually get this live in the system. The benefit would still be effective January 1st, but it would still be held and not processed until that actually got set up within the system. And then, of course, we would see plan language changes coming into effect late also, because again, we would be at the back of the bus, so to speak, for getting those services updated. But all of that would come through in 2026 at some point. And I'm trying to see if I can, and here's the information that I have about the telehealth services. For 2025, there were 326 members that sought services. The member paid $26,998. The plan paid $158. So this amount, this $26,998, would be absorbed by NDPHIT going forward. You know, if we had had telehealth at 100%, 26,000 more would be paid by NDPHIT. Just as a comparative, this is only data through September of 2025, so a full year of data for 2024. And this is both pools, by the way, October and January. We only had 398 members for a total of 33,000. And I looked at 2022's data when we were coming off the tail end of COVID, and the maximum there was only like $40,000 or $42,000 that was paid, even in the highest utilization period. So the cost to absorb telehealth is nominal, and it's a win for the members because it's $0 to the member to do those telehealth services. So I believe we would just need confirmation from the board as to whether or not they wanted to opt out for the January 1 implementation.
Like, what are the wishes of the board? It seems like this is a good idea with a minimal cost.
Yeah, I agree. If we're looking for a motion to move forward to not, or to opt in, do we need to opt in, or it's
automatic? If you,
okay.
You'd have to opt out. Yeah.
Okay. Well, I would say to support the new elected coverage of telehealth in our plan.
I second that, and just to confirm, that is we will be automatically in there January 1. The October pool would go in at some point once they're added at a later date.
The October pool would not go in until 10/1 at renewal, unless we specifically go back to Blue Cross and say, hey, can you add them in as of January 1, 2026 and push that through? But we wouldn't know, because again, it's the entire Blue Cross book that's moving to this. So we'd be at the back of the bus in terms of getting this benefit. But it could, and we're still waiting for them to confirm that they can actually do it. So as of today, if we don't do anything, they would automatically opt in as of 10/1/2026.
So do we want, I guess the clarification would be, do we want them, is your intention for the motion to include if we're able to bring October in, that we move forward that way as well, I guess, would maybe be the clarifier there? Or do we let October renew at October renewal?
Jenny, you made the original motion, but my second would be to add October in if we're allowed.
Yeah, I would agree. I think if
Okay.
they're able to get them in earlier, then to do that, but if for some legal reason they can't and it has to be October 1, then that would be fine. But if they can get in
Okay.
earlier, that would be my motion.
Okay.
Looks like we have a motion and a second to support with some information. Any discussion? Desi? No. Any discussion? Any discussion? All those in favor of the motion signify by saying aye.
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 Any opposed? All right, motion carried. Next, Stephanie, are you still rocking through this?
I believe Randy is taking over on the next item.
Okay.
Sorry, my system is just slow.
That's all right. What I'm going to be sharing at the front end of this is just a few summary slides of it's an employer survey and study that Brown & Brown did with sent out to all of our self-funded clients. We had over 1,200 employers respond to the survey. And the survey is designed to give feedback as to kind of their assessment of priorities, strategies, and their impacts that they're having as an employer. The groups that respond, of the 1,200, almost all of them are self-funded, larger employers. So they would be considered as, to some degree, as a comparable to the trust. In other words, there's multiple industries that are involved, public and private. So it's just helpful to have some type of feedback as to what's going on, not just in a marketplace where we're at in North Dakota, but also across the country. So if you go with the next slide, we'll get into a little bit of detail of that. And there are some common themes that we'll see here in the feedback from these employers. So employers are prioritizing cost containment with smarter plan design and targeted pharmacy management. If I were to say in a nutshell of the theme that I sit on calls every single week of my colleagues throughout the country, this is the same theme that's being discussed amongst employers, and that is cost containment and its plan design and its pharmacy. And that is balanced obviously with the goal of talent attraction and retention, which means that they have to make it not only attractive to come there, but affordable to those that they bring on in terms of the plan and the benefits that they're offering. The third thing is the well-being, mental health, and parental leave programs were, as feedback, expanding with several employers throughout the country and planned for in 2026. The biggest concern that I think everybody is just aware of is the inflation, the economic volatility that's driving some of this. And then the last thing is, which we're going to be speaking to a little bit, is the innovative solutions. In other words, everybody is thinking out of the box. Things that worked in the past will not work, and we're seeing it with our own clients. We've had to make major adjustments. I always say it's almost like a common theme too with some of our clients. You got to get comfortable being uncomfortable, and that's because of the volatility that we're seeing across the board. Go to the next one. So we've shared these top three kind of challenges, which is cost, the diverse workforce that's coming in, and regulation of some of the compliance elements. Some states are much more aggressive in the compliance side that are creating challenges. than in North Dakota. So some of those states have, the state is taking very aggressive positions with some of the employer programs. The next one is, again, just the idea of controlling cost for the employer, the individual, and then the attraction of the talent. Next slide. So what are the areas in terms of the challenge? It's medical contributions, significant changes that the employers have decided, hey, contributions cannot be the same in terms of the way we've done in the past. And then some are making the moderate changes. The next one is the plan design. 30%, whoops, go back a little bit, are making the plan design changes, and 45% are making moderate changes. So some of them are significant. And then the well-being programs, which is up from the prior periods, is in the well-being area. And we'll speak a little bit more detail in just a minute on that. So I thought it would be helpful, because we're going to have this discussion on out-of-pocket max and our plan standardization. This is, and there's a lot more detail on the NDPHIT data that will be shared. But when you look at the out-of-pocket max on the HDHP plans that are offered, generally it's around 3,400 with the NDPHIT members, and on the PPO programs it's under 3,000, which is the most common one that we see in being offered to the NDPHIT current members. The other thing that's important is that if you look at a comparative HSA contributions by other school districts throughout the state of North Dakota, none of them are making contributions to an HSA, and none of them are doing 403B programs. It's only the smaller school districts that have adopted that 403B concept, which the HSA, anytime you insulate or divert, I think we've talked about this before, but give incentives for people that can affect your risk pool, then it creates the unintended consequences of higher inflation, higher trend, and adverse selection. So when you compare just this baseline of information to other school districts that are self-funded in the state, hopefully it's telling. So we just took on another large school district as self-funded, and it's all public information, so I can share this information. Minot Public Schools, we just recently took on as a new client. Their composite cost per employee per year with a low out-of-pocket, and I'm not picking on them, it's just known information, okay? In that their cost per employee per year is a little over $18,100. To give you some comparative of a self-funded plan who has made probably 3 or 4 major adjustment changes over the last few years that we worked with them, as West Fargo Public Schools. And their cost per employee per year is slightly over $12,000. If West Fargo had to pay the same cost that Minot is paying per employee per year for their school, for their employees, it would cost them $7.4 million more for their health plan. That is significant. And I would attribute the majority, again, of that comparative, and the other groups that are doing the larger out-of-pockets that are described here are achieving similar results in terms of the cost per employee per year. I can tell you the closest one that it is to Minot is probably close to $14,000 a year. So even if it's a delta of $4,000 per year per employee to a education budget, it's significant. And so I think this is important and relevant in the fact that the industry at large is making the changes, public entities are making the changes. And so knowing this information hopefully will give better context to what has to be done, but then the comparative on the educational side to the school districts and to the public entities that are part of NDPHIT is also going to be important. So sharing data, I think, would lend hopefully some, credibility and credence as to, why the standardization has to occur. You cannot continue to, as we've shared before, the inflationary factors are too significant that are affecting both utilization and cost. That having an out-of-pocket less than $3,000 is just not sustainable. Go to the next one.
Question for you, Randy.
Yeah.
I don't know if I picked up, I maybe missed it, but you were like giving you said something like was it 17,000 per employee or 18,000? I can't remember.
18,000 per employee per year.
And then you said West Fargo was at 12,000?
Yeah.
Did you give NDPHITs per employee?
Well, it's a little, we do have it. In fact, it's on the stewardship report. I was going to pull that up because I was going to isolate it by pool. And I meant to include that in there, but I will add it before we send it out to everybody.
Okay.
But NDPHIT is lower than Minot for sure, but it's still higher than West Fargo and some of the other school districts. But that was the whole idea too, Mike, is that I thought it would be helpful to kind of share that on a comparative basis so you can look at contributions. A lot of times we'll do benchmarking for contributions, as well as the plan cost, as well as the plan benefits. So if we were to take a demographic that's similar in size to the populations or the school districts or the public entities and do some benchmarking so they can see what other employers and even within the state or the communities are doing where they're making these changes and so they can ultimately see where everybody is here. We're in this small quartile that is an outlier, if you would, to everybody else. So anyway, we'll make sure that information is included and updated on that comparative matrix that I sent, or that chart. So the other areas, I'll just focus on the plan management, and that is it's your stop losses at the top of the kind of strategy areas, pharmacy, as we talked about, and doing the RFP process of trying to leverage the market. So we talked about it before, but standardization gives us the leverage to do more of the RFP process to get more respondents, to do carve outs. And I'll speak a little bit more about that in a minute. Go to the next one. And then the other top areas that they're focusing on the well-being is in chronic care management. You saw, some of the Digby information. They're focused in metabolic health, but it also the whole concept behind Digby is that there are other areas clinically that they're impacting, and the one kind of really positive highlight that we see is a reverse trend with NDPHIT that I'll share in a minute on kind of the stewardship, is that the pharmacy cost has gone down 7%, which the industry on average has gone up 13% this year. So that's, and validating that through the study that Digby will do, that's going to be important, and it's going to give more detail as to what areas they're affecting. I think we shared the last time the Blue Cross report that they even acknowledged the first 2 quarters of this year were significantly lower, both in pharmacy and some of these other even high cost pharmacy claims. Wellbeing platform, we do have the Blue Cross .me as a platform option, and then weight management. This is compared to the nationwide survey, but the positive thing is that I think is important to note is that we've actually been proactive ahead of the curve on some of these areas to help our population. Next one. So this is a busy slide, and I'm not going to go through every one of these ideas. You can read it after, but managing high cost claimant is coming from plan design revisions, as we talked about, pharmacy management, One area that that we would love to explore is some of these disruptive PBMs. Prime Therapeutics is not a disruptive, PBM. They're set in their system and they're set with the Blue Cross process. And again, employers nationwide are saying that's no longer acceptable. We're going to challenge every kind of vendor structure we have in place, and particularly pharmacy, because it's such a high cost area. So international sourcing and drug formulary carve outs, those are all some of the examples that disruptive PBMs do. Third-party vendors to help manage high-cost claimants. If we were to market, that's, again, we've talked about that before, getting stop-loss marketing, proactive education programs. There's a program out there called BAI, it's called Benefits All In, that has grown significantly the last 3 years, I would say. And what they do is they actually do an assessment through the open enrollment process on the entire population to say, are you eligible for Medicare? Are you eligible for Medicaid? Are there state-based programs? Are there charitable organizations? They help some of these most costly individuals actually find other options that the individuals could look at. It's all voluntary, but they've had a very high success rate in helping some of those individuals because they can actually, in some cases, eliminate all the costs for the member on those high cost situations that they're involved in. Nonprofit advocacy groups, there's one called the Samaritan Fund that's out there that's also grown significantly throughout the country. And then the contribution alignments, avoids spousal surcharges. That we find some companies say, hey, we're going to surcharge the spouse. Actually, we find that to be the detriment of a plan. And then eliminate the non-benefit incentive payments like the 403B alternative option. Next one. And so this is again the national survey. They're getting, it's basically a 14.5x on utilization that's occurring in 2025. The 9% forecast, this was about 2 months ago. It's actually moved up to between 10 and 12% now that employers are forecasting. And it's the catastrophic claimants that have increased, as well as the prescription drugs. This is again more national data on that's been discussed. Hold on a second here. Next one. And then here's the plan for performance. So here's the thing that I kind of wanted to highlight in a couple of areas. One is if you start kind of where the red means that we've had increased cost, and the green means we've had a reduction. So it's really a kind of an interesting slide. But the medical admin has gone up slightly. The rebates have gone up actually, which is actually money back to us. Stop loss has gone up 20%, which we actually forecasted in our underwriting, but that did increase from the prior year. Medical costs have decreased almost 11%, and the RX has decreased 7.5%, which is what I indicated before. Even if you add the GLP-1s we're doing through the compounding, the pharmacy cost is still lower compared to the prior year. Then the amount over spec. Now, last year was probably not a fair comparison because we had a large claimant that got reimbursed, but that did go down. And what that really means is if we have a low loss ratio, we will get that 20% refund for both pools. Probably we're kind of forecasting that for the January pool and for the October pool that we'll have a 20% refund. So that will help. We just got one for last year for the January pool, and I think it was around close to 400,000. Eligible claims have actually gone up. That's a utilization factor. So that's an interesting observation. So the utilization overall has increased that 9.2%. Then this is the area that really caught my attention, and I challenged our team to look at all this data over the last probably month and a half to figure out what's going on here. Our collected contributions have only gone up 3.8%. Now, why was that number kind of relevant? Because our forecasted premium renewal increase even averaged between the two pools was somewhere, it was supposed to be between 7 and 8%. So why, if we had a renewal increase of 7 to 8%, would we only collect 3.8% on the increase? Well, there are some reasons, and I'll explain to you after we dug into it. But our costs have gone up 9.7% from the prior year. But if we're only collecting 3.8% more in contributions, you can see that's automatically a delta of a negative. So what is causing it? So when we looked at January pool, the collected premium change, that when we looked at the actual money collected in a dollar basis, it was 6.89%. That was good. But that was reflected because we actually had an increase in membership, not because we got the per unit or per employee per month increase. So that 2.79% actually resulted in 6.89% increase in overall premium for the January pool. Our renewal forecast was 5.06% because they actually in the prior period had a really good, they had a lower trending rate. But our net for January was 2.79%. Okay. Why did it occur? Well, we had a shift in enrollment demographic to more singles from the tiers of families and employee spouses, which lowered our unit costs collected. So our net collected premium resulted in a deficit from what we forecasted on where our premium increase was supposed to be on a PEPM by 2.27%, which was $737,000. So that was the January pool. If you go to October, it's a similar thing. So our premium change period, we actually collected 10.414, 2.89% was reflected to the membership increase. Our renewal forecast was actually 9.28% for October. Our net collected was 7.04. So again, we saw a slight shift from tiers going from families to employee spouses to employee only coverage. And the net effect is it was a deficit collection of 2.24% or of $676,000. If you go to the next one. So where does this put us? We're based on what we're seeing in the data and also just general inflation, 9 to 10% medical inflation, 13% inflation on the pharmacy side of it, 20 to 25% on stop loss. Admin, we're forecasting 5%. But if we're going to get our pool to be in the position to be continued to be, in the positive way, we're probably, going to have to add 2% on our premium increase to next year for our deficit. And then overall, when you add all of it, including that 2%, we're looking at 12 to 15% increase. So I know that's not what we wanted to hear or what we anticipated, but it's the reality of what these other forces that are occurring, both inflationary, but I would say the utilization component is driven significantly by the plan design. So anyway, I'll stop there. I covered lots of ground. I'll leave it up to questions now.
Yeah, Randy, I have a question for you in regards to family plans being switched to single plans, but by removing all of those folks off the plans, wouldn't the claims also be reduced? Because if you had, you know what I'm saying? Like if you have a spouse and children and well, usually children are pretty healthy, but wouldn't the claims be reduced because you have fewer people we're covering?
Let's say that the families and employee spouses, particularly in the older age employee spouses that we see stay. Though if I were to segment the demographic that probably has the biggest effect on our cost that continues to go up significantly are age 55 and older. Okay, so you can bring on more healthy single ones, but if your cost for that other demographic is pushing your overall cost significantly higher, they didn't leave the plan, they stayed. And not only did they stay, but they're incurring more cost.
So our healthier folks switched from family plans to
There you
single
go.
plans. That's what you're saying. Okay.
Yep.
Okay.
So we had that shift in demographic is, and it's more, it's just the correlation deduction that we're getting to until we can substantiate it. But what we saw is this increase in the singles, and we usually see healthy single people, but the opposite of that is occurring in that older demographic. They're staying longer, working longer, not necessarily all moving to Medicare. Because I showed that report on the last board meeting where it showed our age 60 and 65 population, that I think the average cost of male 65 was $55,000 a year, which every year has gone up from 30 to 40 to 55,000 per person. So every increment of those individuals that stay on the plan, it's a multiplier to our cost effectively.
So we'll be only offering so many plans, hopefully reduce our increase.
Yeah. So here's the issue is that this is when I showed you that comparison of where the other self-funded groups have moved to the higher out of pocket. Let me tell you where we've seen it, the change, I should say. There is an element of migration. In other words, some of those individuals now that are Medicare eligible say, hey, now you have a $10,000 out of pocket you have to pay. Guess where they're going? They're going to Medicare because they don't want to pay $10,000 out of pocket. As long as we keep it under a threshold of $3,000 of their out of pocket and they compare it to Medicare, they're always going to default to the employer plan. So that's just one demographic that we've seen historically when the employers have made those changes. You've seen this migration of some of the highest cost claimants actually leave the plan. So any other questions on this?
I guess, Randy, this is Cole, just to clarify, the things that we've done in the past, if I'm understanding what you're showing on this slide, really haven't worked because of outside forces. Because when I see 12 to 15%, and I look over what we've done the last 2 or 3 years, the intent was to not have these increases. And now here we are having the same discussion.
Okay, fair question. If you look at our cost on the medical, the actual medical claims, at least the prior year that I showed you, our pharmacy's gone down and our medical's gone down. These two areas right here. So if we hadn't made these moves, it would be far worse. But what is holding us back to a degree is the fact that we can't use some of the leverage that we could get in standardization and making the plan out of pocket changes that we that we've suggested to make, only because it's not just the right thing to do. It's competitive with the market, but then we just have to always remember we're actually competing with whatever choice that someone is comparing us to stay on our plan, and especially with the high cost claimants.
So then to follow up then would be when, to Jenny's point, if there are individuals switching their plans from family to employee spouse or just employee, is that due to not only our rates and or the employer only covering 20 or 80% of it?
A contribution does have a significant part of it.
Because if you're covering 100% of it, not necessarily all schools or city, counties, parks do, but if they do, why would they leave on that component? That's what I'm trying to get a handle on.
Yeah, so it's some school districts, a lot of them only pay at the single rate. So they're disincentivizing you to cover dependents. And then the ones that do join, they have no other option, and they're usually high cost. There's a lot of correlation to high cost claimants for those individuals.
And the final question, which probably the school folks are going to shake their head at me, but we've been trying to standardize these plans. Is that part of the reason why we have these potential increases, because of all these different plans? And by standardizing it to 4 plans, that will help eliminate it or not?
Well, it certainly helps to eliminate the variation and the predictability. So I think we'd all agree that if you can standardize what your comparative options are, you just have more ability to manage your risk pool.
I think I had a course pre-meeting on this with Randy and Zeke, and so we talked about all of this at length, because I mean it's the same thing like Cole, you were alluding to, like we've been doing these things 12 to 15%. We know that that's going to be a communication issue, right? To our political subs and our school districts. But wait a minute, you promised me this, and yeah, we did. You know, the world has changed. I don't know what to tell you. This stuff is expensive. And at the end of the day, we've got unrealistic plans that you could deal with, but now they're too dang expensive. I mean, I looked at like I know Randy and Brown and Brown, they manage a few different school districts, like Jamestown, for example. I asked Rob Leck, Rob, what was your increase? Well, actually, I think he said it was a 0. I don't even, I mean, it was ridiculously low. Well, I look at his plan, it's because his plan, in our opinion, if you've had like our plan, isn't great. Like we would look at it and be like, ugh, yuck, you know, like I'm doing a side by side because I'm trying to get my district and teachers to understand that we like quit talking about the good old days. We cannot afford that plan anymore. Like, for example, in Jamestown School District, correct me if I'm wrong, in-network, out-of-pocket max for a single is $9,200.
Yep, we just changed it this year. They moved it to 90. It was lower, but then it's 92. Yep, right there.
A family plan, $18,400 out-of-pocket max. In our district, our out-of-pocket max, and we're above actually the $3,000, not by much, $3,500 for a single, and $7,000. So I can tell you, yeah, my district would lose their mind when they look at that. But there's a reason, and I think at the end of the day, we're just trying to, you know, stop the blood loss here, I guess, so to speak, the hemorrhaging of our budgets when we look at trying to maintain these plans we can't do it anymore. And I don't know how to explain that to the rest of the NDPHIT or other districts but we can't do it. If we're wanting, at the end of the day, if we want like those 3% and 4% increases, which is what I want, then I can use it for salaries, you know, and other things, you know.
Yep.
So I just think it sort of makes it extremely important that we move towards standardization. I wish it was the good old days where we could afford them, but I don't know.
But it's not just us, you know, it's not just NDPHIT, it's across the board everywhere.
It is.
Randy?
That's the reason why doing the benchmarking is helpful. Again, if you, my thought was if we get more contextual comparison, both at a leadership level as well as us when we're meeting with groups, it might provide maybe some, you know, semblance of education and understanding of why you can't do that. Just like I shared what, you know, about the comparison between Minot and West Fargo, to think that they would have to pay, you know, $7.4 million at West Fargo to adopt the same plan coverage, it'd be ridiculous.
So Randy, if anything happened at the federal level where, I don't know if this has any impact on this with the ACA or Obamacare, what do you want to call it? If that was to go away, does that help us or hurt us?
Well, it could hurt us. So let me tell you, I'm glad you brought that up, Cole, because this is important. Remember, I always say it's a chess game. So whatever happens here is that we got to think about staying ahead of it. So what could happen is if people lose subsidy and they're currently maybe taking subsidy and they're taking it because they pay nothing, and that happens, you know, you can the way that the subsidies have worked on the ACA, some of these people are not on some of the employer plans because they're taking 100% of the subsidy, paying nothing. So they could be some of your highest cost individuals because there are no health questions asked when you go to the exchange, other than you have to be in the enrollment period or you have to substantiate loss of coverage to get it. So if they come now without a subsidy, it's like, guess what? That employer plan looks really attractive, even though it's some money out of my pocket. So if I'm a high cost claimant, again, they're always looking at what's my out of pocket.
The other aspect of that with regard to Medicare is if there are changes in Medicare, and even on the ACA, if you start to see more emergency room visits, if the providers aren't getting their reimbursements under Medicare, they shift those expenses to insured plans. So you will see when there are changes in Medicare that reduce the charge masters for Medicare reimbursements, they will make up the difference when they bill their insured plans. And so, you know, depending on what the negotiation is with Blue Cross Blue Shield and their contracts, if it's a percent of a billed charge, they can adjust their billed charge. Your percent still stays the same, but it's a percent discount off of a higher billed charge. So we will see historically that when you have changes in ACA and Medicare, the cost shift goes directly to insured plans because the insured plans will pay.
I'm glad you brought that up, Stephanie, because one other thing that I've seen happen, specifically in North Dakota, the majority of your hospitals in rural communities are critical access hospitals. They're the first to get hit with these changes. And so what has to, just to Stephanie's point, they cost shift back to the private industry when they can't collect enough money to fund their budgets for the critical access hospitals.
But I kind of, and Keith is going to laugh, but I liken this to my daughter's in commercial insurance. And she talks about how the whole commercial insurance side of the thing is changing and deductibles and what's covered, what's not covered, what's depreciated out. They've all had to make these changes for basically the same reason what we're doing here today is adapting. My question goes to that 12 to 15%. Is that something that we're potentially looking at for 27 rates? And then,
yep,
you know, the question,
27.
yeah. So the question I'm going to ask is what happens in 28 and 29 if we don't work?
Well, one thing we didn't take into account is that if we make the plan changes, we have not given any of the, what we call actuarial value credit to an adjustment to that increase. So let's say that groups do take like the $10,000 out of pocket plan, because this was asked before, would they get it? Would they get some rate relief? The answer is yes, they would. So that's the way to help kind of create some leverage, if you would, for the groups to consider some of these plan changes we're going to recommend is, hey, I don't want that 10 to 12% or whatever the number is. Give me something much less than that. Okay, here's what you can do. Go to a plan like Jamestown Public Schools as an example to Mike's comparison. And you will not have to pay that 12 to 15%. You will get an actuarial plan value credit for making the plan change.
But I think that's a false anomaly that we're trying to pass is like, you're going to have a 10,000 out of pocket, somebody making $55,000 a year. I mean, it just, that I struggle with that. I understand that we're trying to keep our costs and we're not trying to pass them all on, but it's like, I don't know. I'm thinking of the young teacher, the young employee making 50, 60 grand with a kid and a wife that's maybe not working or stay at home. And that's 10,000 out of pocket. That's detrimental.
Yeah. And to your point, Cole, the important thing about that, when we do these plan changes, that we show the data to the groups, that it's usually less than 3% of their population that actually gets affected.
I mean, that'd be a lot of medical bills, Cole, for them to hit the $10,000 out of pocket, with co-insurance and deductible,
And that's not the average. The average is more into the 5 to 10,000, but that 3% is the high cost claimant area.
I see our negotiations going where single plan, say it's 11,000. Say we get the high deductible and it's not, I don't know, cost 9,000 for a plan. That extra 2,000 that the school would be saving would probably be going into something because that's what they're going to fight for with our unions. But my other thought is, when they know we're switching these plans, I'm pretty sure everybody's going to go get everything checked out that they need to before it switches.
Yeah, and which they should do. And honestly, and that is when they look at the market, I can tell you the market is above our numbers in terms of cost. That's why some of these groups that did look, they actually didn't leave.
Randy, how big of an impact does the stop loss rate that we pay have on that overall 12 to 15% increase?
Yes, that's a good question. So if you, Stephanie, go back to the stewardship. And if you can make that stewardship slide just a, I don't know if we can make it bigger, but yeah, so look at go back, sorry. If you look at the PEPM, so if you look at the PEPM on the stop loss, what is that numbers? Is it 3? I can't see. It's 300. The average monthly is what, 3 something? I can't see it. Not that number. The average monthly. Where's the PEPM? Does it not listed there? Oh, maybe it's not on this one.
Is there any way you can zoom it in?
I don't know if it's well,
The
probably,
PPM on the stop loss is 98.70.
oh, there you go. 98.70. 98.70 divided into the planned cost of 1388. That's so yeah, if you take that 70 divided into the yeah. Oh, there you go. Much better. 99.70, and then just slide over a little bit, you'll see the 1300 plan cost number right there.
Which 1300?
Yeah, keep on going to the right a little bit.
There we go.
More to the right, where it says just total plan cost column.
Right here.
No, keep going.
Right here.
Yeah, 1358. So that's the percentage right there. So $90 or yeah, whatever that number is divided into the 1358.
And where I
Answer your question, Keith?
Yeah, it does. What I'm wondering is, with standardizing the plans, if we're able to get a better rate on the stop loss, so it's even with that, we might not have that significant of an impact on the overall increase that you're showing there.
Yes. So those are, so when we standardize what we shared this a while ago, but we'll get more carriers to actually bid for options for us. That being the pharmacy as well as stop loss.
So there are a few of you who are new on the board, but we did take NDPHIT out to bid several years ago, and everyone declined to quote on it because we had over 60 plans, and no carrier would touch that because they can't afford to build out 60 plans. And so part of the standardization, if we want to be able to leverage NDPHIT's membership in the marketplace, we're going to need a standardized plan that is manageable by any vendor who would be looking at us. And then you would use that, even if you don't move, at least Blue Cross would know that there's competition.
Yeah.
So Randy is good at providing doom and gloom, which is
well,
which is why we
just consulted. We should, to help the fiduciaries.
Yeah. I think this maybe is a segue into our plan standardization conversation, which I know was tabled, I believe, because we wanted an addition of a 90-10 plan.
Yeah.
Which you should have all received. I know that Angie pushed it out shortly after the board meeting last time. I, of course, wasn't there, which is probably why I wasted 20 minutes earlier for everybody. I think let's maybe move into that neck of the woods here. That part of the conversation, is that the right direction, Randy, or did you have anything else to add?
No, well, that was my section. I don't. For today's meeting, that was kind of the scope we were covering, and then I think in December, we were planning to dive much deeper into that discussion.
Okay, so you're not looking for.
Maybe Stephanie's got it up. Sorry. Go ahead, Steph.
So these were the plans that we had talked about last time in terms of, the committee reviewed them. We presented them to the board. The board approved them. The last discussion we had, there was a question of adding a co-insurance benefit of 90-10 because all of the options that we offer are 20% coinsurance, so 80-20 coinsurance plans. And we have a lot of the groups out there under our January renewals that are actually at a 90-10 plan. So the request from the board was to see a 90-10 plan, which we did send several weeks ago. Angie sent that out. This is just bringing it all together to show you these are the plans that had been previously approved. And then the new edition of the plan is this 90-10 plan here. Sorry, that didn't work out very good. So this plan here is our 90-10 plan. So the question is, are these still the plans? And these are our HDHP options. Are these still the plans? Again, these have been previously approved. Are these still the plans that we want to move forward with and just add the 90-10 plan to that? And if we need to revisit this in December, then we can.
I don't know if this is the place to share this, but when Randy was at our annual conference in October, and Keith, I think you may have had a discussion similar to what I had with Randy, was, you know, we're looking at standardizing our plans, which I think is the direction to go. But we talk to our members a lot about having the autonomy and the flexibility and kind of a say in how we operate the NDPHIT trust. And one of the things that Randy and I talked about is, you know, letting our members know, and I think you alluded to that, Mike, in our annual report with your letter stating that, hey, there might be some changes coming down and some standardization of our plans. But, you know, do we do a survey to our membership to say, hey, this is the direction we're looking to go based on health, you know, increases, and how would you all feel being able to pick from these 6? You know, is this a doable thing? And maybe I don't know if we'd be shooting ourselves in the foot by doing that or not, but I'm just wondering if it would be better to provide at least some input or some feedback from our NDPHIT membership before we move forward with just saying these are our plans. I don't know. Randy, I don't know if you have anything more to add, but we did talk about that at our conference because, yeah.
Good point, Jenny. And the issue is that could you give, again, it's in a survey, again, because you'll get very vocal people sometimes that's like, no, that's never going to happen. So you have to really frame your questions. I think it's important, and it could be very instructive for us for feedback, but it's how we frame the questions so that we don't set ourselves up for kind of failure to it, but also give people the right context for how they're answering it. So in other words, it's here's the kind of the forecast for cost. Here's some options in plan design. Literally, it's you're trying to get them to decide, hey, would you rather have this as your cost exposure versus a plan adjustment that's going to stabilize your cost? And because when you compare, what most people are really interested is, for again, going back to the 95 to 5%, 95% really care most about their paycheck, and they're willing to concede on benefits if they know that they're not taking a big hit on paycheck. So that's just one example when you're doing a survey that you're wanting to give people a comparative to say, what do I value most? And then effectively you can essentially get their feedback, but at the same time, get them to the deduction that, hey, this has got to be kind of the direction we have to go.
I think I question if we can educate them enough to understand, because what I think they'll look at is at number one, when we came to NDPHIT, that you promised a grandfathered plan. So I think any deviation from that is going to be like, nope, right? Depending on who, and I don't know, like, how do you educate them to get them to understand that, like, this is an unsustainable thing? But maybe there's some information that we can glean from that. I don't know.
Would it change the direction you're going?
I don't think we have a choice personally, but
Well, and I was thinking the survey would maybe go more to our administrators, not necessarily our entire membership. Because it would really be our administrators who would be making that decision along with, county commissions, school board type. I wasn't thinking it would go to actual members, because I think that's a whole nother can of worms, but at least from the administrator's standpoint, I don't know, just something to think about.
I think you'll get the same answers what Mike said.
I think being the person that had to explain to my board when we were going to make a change, or I guess the importance of making that change, the education piece that Mike was talking about is huge, and I don't know if it's realistic to get all of these administrators and commissioners and officials that are going to make the decision together to get them to give them the information and help them understand. I don't know if that's realistic, but I know that it's going to fall to somebody's shoulders in every organization to help those people understand. And I know it's a tough sell when you're an HR person or a county administrator or whoever it is that has to explain that. It's difficult.
Would that be beneficial though, to at least solicit their feedback in some manner so we understand what issues they're going to face? Like, we understand for our own organizations pretty well, but every organization in North Dakota is different. And, if that's able, if we're able to utilize that information on the communication side, and, just as you said, Mike, it seems like we have to go this way. It's just what it is. But to help them communicate that to the rest of their employees would probably be a better partnership than just saying, this is how it is. Good luck.
And I kind of go back to what you guys do at NDPHIT when you guys have your annual meeting, is maybe we could do it that weekend or that day before HR collaborative and invite the powers to be and what they want to bring elected officials and make the presentation that you're seeing here today with the financial numbers to educate them. And then those that want to stay the next day for the HR collaborative could, and the rest could head home that night or the next morning, depending on but I like the idea of doing it in person so they actually can have a conversation.
Mm-hmm.
And there's other forums, Mike, maybe like the NDCEL, where you can do a similar thing with the superintendents and the business managers.
Fall conference, probably.
Yeah.
well, we could do Zooms too. Like, that's the other thing. It's like you could do that in the next month for superintendents. You could just be like, look, all NDPHIT members, I could reach out and I'd probably get a better turnout than maybe, if Randy sent out an email to the folks, but where we just talk about these things and try to build their understanding,
But I don't know when you guys start your budgets, but for park districts, cities and counties, we're usually in April because we have to have our first reading in August. So whatever we're going to have to plan for rate increase is going to have to be communicated at least by March, April.
Well, for districts, like we're a 2-year agreement, which a lot of districts do that, some don't. We will be building ours because we have an agreement done already that, February, March, a little bit earlier than normal.
Yeah, we'll have October's preliminary renewal by the February.
February.
Yeah, that's
end of
when
February.
we'll have it ready. And then shortly thereafter, we'll have the January one. So that these two or these other mediums could be, I think, I agree. It's the idea that you bring the right people to those environments where you spend time educating them and having a feedback discussion on it.
We don't get great turnout at midwinter for superintendents. It just is, it's a better fall already is gone. We tried to put a breakout, but NDCL didn't seem to want it. So Randy and I got denied. So, maybe we could just do our own deal for schools. I would be happy trying to lead that a little bit.
I think a Zoom call would be good, and if Randy could be there to explain some of the stuff.
Yeah.
I think that would be good too, Mike. I think especially if it targeted the NDPHIT members and their business managers. So you had both in the room listening at the same time. And then you could even include board presidents too, if you really wanted to, have all three as part of that. And if it came from you, Mike, I think you probably would get a pretty good representation of NDPHIT. And I think that that's probably a good idea, as Jenny said, to share what's being discussed, maybe before a final decision is made. At least then it shows that we are continuously seeking feedback from our membership before changes are being put into effect. And maybe they'll come out on the positive side of this and recognize, as Mike said, the doom and gloom that Randy sometimes presents is the reality of the situation. And we're all dealing with the reality of the numbers that we have presented to us.
And just so you know, Mike, I did have a conversation with Levi this week and moving into his new role. He said he would be willing to do whatever we asked him to do to help us to educate the other school districts about the changes he had to make with his school board. He said, I'm sure he'll join that Zoom meeting if we want him to, where he can kind of field a lot of questions, because he strongly believes, in the changes they made, that's allowed them to be sustainable, not only in their health plan, but to pass on those savings onto the teachers and educators and the staff for, raises.
Okay. How about this? Just kind of, we're getting near the end here, just to sort of get a plan. So how about somebody from the political sub that world, I can try to run with this school side of things and set up a Zoom and just do reaching out and work with Randy on that. Does somebody from political sub want to do the same? And then we push this ultimate decision, I guess, to December or, probably January. I don't know.
Mike, are you essentially, the way you're looking at it is to host a separate webinar, or are you doing it in conjunction with an event?
I would do a separate webinar. I just would probably, quite honestly, reach out to NDCL because they do a 10 o'clock coffee chat. Then I would just say, Amy, let me commandeer that time, because that seems like a time where at least our field is kind of around. And then I would find a way to reach out directly to each superintendent, business manager, and say, look, you got to have somebody in the room at this meeting and get there, kind of a thing is what I'm thinking right now.
So Mike, if I understand you would like the political subs to also get together in the very near future before December.
I think that makes sense.
Okay.
Maybe Desi, you and Shannon, since you two have made the biggest changes of all the political subs, you might be able to help. If Jenny wants to be a part of that too, that's just an idea and thought, because I think people that can tell the story about the change is really helpful to address questions, and then kind of giving some direction as to how they may want to deal with it internally at each organization.
Okay. Jenny, would you want to be a part of that group?
Is she on anymore?
Oh, did she leave? We'll volunteer her if she left.
I'm here. Can you, yeah, am I working again? My microphone seems to be going in and out. Yeah, we would have no problem assisting even from the webinar standpoint. We do them all the time. So, yeah, we can work with our professional development manager to set something up. But then would that be for all political subs? Do we want to be looking at bringing in parks and cities? And I mean, I think we should, but
yeah.
Okay.
And Jenny and Desi, if you kind of lead that side of it, I'll be more than happy to coordinate that with you as well, with our team to help facilitate that.
Okay.
So Desi and Jenny, then, are we wanting the parks to be part of yours, or am I doing a completely separate one? Because we only got probably 25 that are participating. I don't even know groups.
Yeah, I think it'd be good to do like our who's in the October pool and who's in the January pool, or schools, and then others like our counties, cities, parks. Yeah, I think we could all do it together. Maybe, yeah. And Cole, maybe if you even just want to be part of the discussion or how we market that, or, you know, get it out, we can work together on figuring that out as well.
The other thing as part of the conversation, the plan designs themselves, but also maybe the timing that we had talked about. So, you know, there was conversation about the 2026 October and 2027 January. That would be like a voluntary, if they were looking at making a change, it would, like, these would be the plans that would be offered to them if they were looking at making a change. And then 2027, 28. So 27 October, 28 January would be when the forced change, for lack of a better word. So maybe make that part of the conversation too, as far as timing and what that looks like, and some of that conversation too, so.
And could we get this all done in an hour or less? I mean, I don't know if people have much more time than that, you know?
I think you have to, I think Randy does the, again, sorry for the words, but does the doom and gloom to start, and then we elaborate as board members. And I'm gonna guess some people don't even know that we were even talking. 80% of people probably don't even know that we're talking about standardizing their plans, even though we said some things. They don't read that. So that might be potential shock. Might be something where you forward the recording of this video. Now, some people won't watch that. A lot of them won't watch it, but maybe you say, hey, it'd be helpful if you'd watch this conversation that we just had here today, in preparation for, you know, what we're about to talk about. Yeah, I don't know.
So Desi, you had asked for some examples in terms of the plan impacts. We had sent that information in the email. Angie had sent that information in the email in terms of how each pool's plans were going to be impacted. But Desi had suggested that we look at the actual dollar impact. And some plans may only be impacted by as low as $250 when they're making those changes, where others may be impacted by, you know, upwards of $1,500 when they're making those changes. So it's not always doom and gloom for every one of those groups. It could actually, you know, like in Desi's example that she provided Angie, it was a nominal impact of $250 to get to one of the standardized plans. So each group is definitely going to have to be reviewed independently. As we knew this all along, but it's definitely something that it's not always going to be necessarily the worst. So Kiana here at Brown & Brown did some preliminary numbers, and in the October pool, sorry, it was just taking me a minute to find them. In the October pool, there are 45 groups that will have additional member exposure as their out-of-pocket is under $3,000. So we have 45 groups with an out-of-pocket max that's under $3,000. The range of that exposure for the October pool is anywhere from $300 to $1,250. So that's the cap, is that the maximum change impact would be $1,250. 20 of those plans would be changing their coinsurance potentially as well. The groups that are above 3,000 or 6,000 would have the options of reducing their out-of-pocket maximum or increasing it, so their liability is harder to predict. So we already have groups that are at the $3,000 out-of-pocket maximum or a $6,000 out-of-pocket maximum. And so they may not be impacted at all, or at least nominally. Again, not as much of a doom and gloom as we would think, because they're already at that at that larger out-of-pocket maximum. So it's hard to say how they might be impacted. For the January pool, there are 29 groups that have an out-of-pocket maximum under $3,000. And the exposure ranges from $250 to $1,500 on the January pools. And then roughly 11 would be changing their coinsurance as well, potentially. If, you know, if they have the 90/10, maybe they can stay with the 90/10 if you guys approve keeping the 90/10. And then again, the groups above 3,000 or 6,000, we would have to, look at each of their plans because they're already at that threshold. So we don't know if they would be impacted negatively or positively. I hope that helps.
Appreciate the data there. Okay, so let's talk timeline here. I know we still have financials that I think we're going to try to approve today. Is that something we have to do? Yeah. Okay. So just want to get a timeline. Our next meeting is December 17th. Can we pull off a meeting? I was like looking at my calendar, like the week of December 1st or December 8th. I'd try to set up a meeting with our membership group. And then kind of be able to report out something on the 17th. Is that fair? Is that too quick turnaround? Okay.
It's hard for me to say because I'd need to visit with our professional development manager. I don't know what she has scheduled for trainings, but I'll just let her know it's pretty urgent that we try to get it done sooner than later and try to shoot for the first week in December.
Okay. And then it'd be helpful just, of course, Randy and team just to give us a pretty cookie cutter presentation that's to the point that is going to not make it so complicated for them to understand why we're doing this. And then, we can probably got to get together before we do the actual thing with you guys too. If it's the week of December 1st, let's get in a Zoom and make sure we're on point with what we're going to do.
Yeah, we'll prepare that.
Okay. All right. So I'll follow up. Sounds like Jenny, Desi, and if there's any other school folks that want to be part of it, I'll make sure that we're coordinating there, and we'll have a report on the 17th as to how our feedback sessions go.
And then Angie, could we get contact information like emails on who we send the invitations to?
Yep.
Okay.
I'll give you those. Because there are some school related ones that are in like the January pool. So I'll pull those out and include those with Mike's instead of yours, because even though they're January, they're more education
School. Yep.
related. So yeah. Do you want me to send it to both you and Desi, Jenny, and then Mike, I'll send it to you.
I think probably just send it to Jenny because she's the one that's going to get with Alicia, right?
Okay.
Yes.
Perfect.
Yep.
Okay. All right. I have to leave like a hard stop at 3, so we have about 7 minutes. I think we just have financials left, correct? Not that you have to hurry, Nora, but
No
I can make
pressure,
it quick.
Nora.
You guys have all seen them. I'm not going to bring much better news, so I'll try and go fast. All right. Okay, can you guys see my screen? Try doing the share.
looks
Yep.
good.
Okay. All right, I'm going to start with the income statement so you guys can see because that obviously flows into the balance sheet. Our earned premium has been consistent, so it's not that our earned premium is bad. It's kind of where we expected. It's been consistent all year. October was not a great month for claims. I know we had that in September as well, but it was one of our largest claim months that we've had, up at 6.4 million in Blue Cross Blue Shield claims and the Digby and stuff, but the majority of it is in Blue Cross Blue Shield. So we had 117% loss ratio for the month of October. Granted, some of it's the timing with, October was they had more Fridays in there, so more billing weeks, things like that, but it was a big one. So it took our year-to-date loss ratio over that 100% for the year. So at 102 for the year. We did have, we've had some cash equivalent interest and stuff coming in. The CDs and stuff have helped to be able to bring more income in instead of just having it in the cash. But it did take us from about $800,000 net loss for the year to 1.8 net loss. Granted, then we'll go up to the balance sheet. We do still have quite a bit in cash. I mean, we are still just under 9.7 in cash and CDs, which all have different time frames when they'll mature. So if we would need the cash, those CDs, they don't take long before one of them will mature. But so we are still sitting in a good cash flow spot. We're not at risk of not being able to pay claims or anything of that nature. but it did take our membership equity from last year. At this time was at 7.6. It is now down to 6.2, just with some of those big months. It could be just the timing of things and we haven't had a month that has been this big that often, but it was something that took it down. So unfortunately, I'm not bringing any better news. So sorry to Randy's discussion. So does anybody, like I said, though, again, we're still sitting good cash flow wise. We're not in a bad spot as far as being able to still pay all the claims that are coming in, again, up at 9.7 between cash and CDs, but it did take our membership equity down a little bit. Questions? Made it speedy for you, Mike.
All right. Appreciate it, Nora. Do we have a motion to approve the financial report? Looks like Kevin.
Kevin, are you motioning? Okay.
Do we have a second?
I'll second. This is Keith.
Keith's seconded. Any discussion? Any discussion? Any discussion? All those in favor of the motion signify by saying aye.
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 Any opposed? Motion carried. All right, our next meeting is December 17th at 1 p.m. virtual. We will have a feedback session between that, and we'll have a report out, and we'll bring back the plan standardization again with hopefully some good feedback from our members. Appreciate your time, guys. Thank you.
Thanks.
Thank you all.
Everybody.
Thanks, everyone.
Thanks, everyone.
Thanks.